what's going on today with COVID-19. So thank you, and here is Dr. Bob.
You know, in the 6 weeks since I last talked, I feel like the world's a snow globe that some 7-year-old picked and shook up. And our world's been turned upside down. So it's important that we have clear communications and honest communications about where we stand in this pandemic, and what it means for us, and how we can get out. So that's my real passion, is helping all of us understand this. I first became interested in pandemics working for Northwestern Mutual, where they routinely study or stress test. We study pandemics as part of a stress test. You know, if a pandemic happens, can we pay the claims we expect? And that was avian flu and SARS and MERS. Then I went to medical college for 10 years as an associate professor. And I am now a consultant for the American Council of Life Insurance in Washington, D.C. Continue to answer their questions about COVID, among other things. So I sort of want to bring us up to date and remind us of where we are. And then I'll take about, I think, 7 to 10 minutes to do that. And then I want to answer your questions. So today, when you have questions, type them in the chat function at the bottom of your screen. And Mary McCormick will read those to me, and I'll try to address them, because the real purpose of my being here today is to answer your questions. This is for you. So once again, pandemics are a part of history. We've always had them, at least since time of recorded history. During prehistory, villages and communities were too isolated to really have, probably have widespread communication of an infectious agent. So in the modern world, vaccines have largely prevented pandemics. You know, our grandparents grew up with pandemics of diphtheria, and that would come through and wipe out a third of the little kids. Or smallpox that did wipe out all of the Native Americans when the Spanish brought it to the New World. Measles is another vaccine that's very effective. So we're sort of waiting for the world to develop an effective vaccine. And I want people not to be overly hopeful. I know we have a lot of excitement about vaccines, and this Moderna one out of England and Switzerland is looking very promising in early studies. But science has been working for an HIV vaccine for 30 years, and they don't have one. They worked for 6 or 7 years to get a vaccine for Ebola. So we could have a lot of people talking about vaccines in the medical community, and then our hopes could be dashed. So I just want people to approach vaccines realistically. It's also important as we go through this to understand that the world today, because scientists want to put out everything they know about coronavirus and share it for other scientists. The world today and public is watching I'll use the word messy process of science unfold in front of their eyes. Scientists make hypotheses, they propose something, then they test it. Sometimes the test fails, sometimes it's right, but not good enough to be solid, but it gives somebody else a platform that they can build on. So we're going to watch scientists throw a lot of stuff up in the air, and some of it will be good, but we're going to have a lot of it that we have to sort through and sift through to really find what's going to lead us to the answers that will help make us better. And just think of the myriad questions we have. If I had it once, can I get it twice? What's the false positive rate of a test? Is an antibody test any good? Can I develop immunity to this? All these kind of scientific questions, let alone the medical questions. How do we treat a patient who has the disease? We don't know. We're working on finding the answers. And the public is going to watch all of that. Now, we have to remember that this is a really bad disease. This scares the hell out of me. Do not underestimate this disease. we are underestimating the death rate, or undercounting. And we know that because in all the communities that have been hit, the total number of deaths recorded exceeds that that we normally expect, and that we normally expect plus COVID deaths. There are still more deaths that occur above that. And those are probably the people who are dying of COVID, but were never tested. So they don't count as a COVID case. Or they had a heart attack and they did not go to the hospital because they were afraid of catching COVID, so they stayed home and died. If you have a heart attack or you break your bones, please go to the hospital. If your children get injured, take them to the hospital. Hospitals have separation, can keep you separate from the COVID areas. But we need to treat normal disease. Right now, COVID is the leading cause of death in America when you look at the number of deaths per week. Somewhere around 15,000 deaths per week from COVID, 12,000 from heart disease, 11,000 from cancer. Accidents are 3,000. So COVID is the leading cause of death. Now, we almost certainly will have more than 100,000 deaths in America by June 1st. There is the question of whether the disease will slow down in the summer. Nobody knows. I personally think it will slow down, but certainly not stop. So instead of 2,500 deaths per day, we may go down to 1,500. I don't see that as any big success. And then we have the question of what happens next fall. Will this be like the 1918 pandemic, where the wave in the fall was significantly larger than the wave in the spring? Or will we have a series of recurring outbreaks around the country? And that may have to do with clusters that form, like in the meat processing plants, or in funerals, or social gatherings, or sporting events. And we could see a variation in how the country opens around the whole country. We have to remember that the success we've had by social distancing has really worked. And when we talk about 20,000 or 15,000 deaths per week, that reflects the social distancing that all of us are doing. When we go back out and interact more with others, we have to continue to stay safe, protect ourselves and others. And we do that by maintaining social distancing, wearing gloves and a mask. Everybody wear a mask. You're wearing a mask mainly to prevent any sneeze or cough or aerosolation of droplets from yourself to others. And you're also getting a bit of a protection from other people who may have sneezed or coughed or breathed heavily into the air if they were infected. So as we move out and about, we're going to have to keep social distance, and we're going to have to wear masks and gloves. Fortunately, the grocery store I go to, today it's about 98% compliance with gloves and masks. Mainly masks, not so much gloves, but mainly masks. Let's talk for a minute about cases in Wisconsin. I'm pleased to say that our cases in Wisconsin are now doubling about every 16 days. So we've nicely flattened the curve. They have not yet started down. So we have to go over the peak and come down. We're still going up, but the going up is much slower. In Wisconsin, on the handout, if everybody printed or can look at the handout that Michelle attached, we've done about 85,000 tests in Wisconsin. We have 8,500 positives. Of those, 1,600 have gone to the hospital, and of those, 350 have died. At the bottom of the second page, I put all the number of positive tests, negative tests, and deaths, and the rate per 100,000 population, which is really the most important number and best way for us to look at this, for Milwaukee, Ozaukee, and Waukesha County. All that information is on the Wisconsin Department of Health COVID page, and it's really an outstanding page. That's one of the best pages in the country. It's just excellent, and everybody should look at it and sort of become familiar with it. It will guide us as we go to reopen, and it will tell us if reopening is backfiring and we need to close back down and go to stay at home. But that's where the information will be coming from. One of the reasons that cases count is that each infected person will, without social distancing and masks, infect 2.5 other people. One infected person will infect 3,000 people at the end of 6 weeks without masks and social distancing. One infected person in a crowded room can infect 10 or 20 people. Take a funeral, take a baseball game, have somebody seated for a couple hours, people are seated around them, somebody's infected and they're coughing, and they're spewing droplets in the air. You're then getting 60 or 90 minutes or 120 minutes of exposure to those droplets if you're sitting near this person. And that's the most dangerous thing you can do, is be in a crowded area for a long period of time with somebody who's ill. You may not know they're ill. They may not know they're ill. But that's how the disease spreads quickly and aggressively. So as we go out, the single worst thing you can do is be in a crowded area. We're going to, as part of working our way through this for the next couple of years, if it's that long till we get a vaccine, need to learn to live without going through crowds or lines. I mean, I don't know how you're going to travel internationally and come back and not get crammed in that little room to go through customs and immigration. But they going to have to figure out how to space people widely apart. And that's part of what the economists and the social scientists are working on as they think about reopening. So, Mary, do we have any questions, or Michelle?
Do, and so thank you. Oh, I'm muted here, so
No, you're not.
Hold the space. I'm not muted. I'm
Nope.
unmuted. Okay, good. All right.
I can hear you.
So from John Frankie, is there a material possibility that there will not be a viable vaccine in the next 2 years?
That has to be a question from an attorney. Only an attorney would use the word material. Yes, that possibility is very real. And we may well end up using a vaccine that is less than perfect. So we're going to accept a certain amount of risk with the vaccine, and or it may be less effective than we really want. So we could compromise and get kind of a half-baked vaccine, and just say that those unwanted side effects are the price to pay. But yes, it is very possible that we will go 2 years and not have a vaccine. The vaccines that are being tried today, and there are boatloads of them, run all the way from a modification of the measles vaccine, which would be really good because we know how to make measles vaccine, to some very new RNA vaccines. The Moderna one is a new RNA vaccine. We've never made or used an RNA vaccine before. We don't have any idea how it's going to work. So there are big risks. Then we don't know how to make it. I mean, maybe it can be made easily, but when we make a vaccine, we're going to need 6 billion doses. That's a lot of vaccine. If it requires a syringe, we're now going to need 6 billion syringes and 6 billion needles dedicated to that purpose. And they're going to have to be made fast, and then they're going to have to be distributed around the world, and then they're going to have to be administered. And this is not going to be an easy task under any stretch of the imagination. But yes, it's very possible we could go 2 years and not have a vaccine.
Okay.
Cheery news, huh?
Cheery news indeed. From Chris Hendricks, do you recommend masks while walking outside and while you're maintaining social distancing outside?
That's a really good question. The official recommendations are actually mixed on that. So I live in Bayside. I can take a walk down my street and not see another soul. So I have my mask in my pocket. If I get near them, we routinely now move to the other side of the street. Everybody's really good at that. And I put on my mask. If I was walking in a park and there were lots of other people around, I would have my mask on the whole time. If I go to a grocery store, and kudos to Americans. Who knew that we could socially distance? Who knew that we could stop hugging or shaking hands? It drives me crazy. But people are very cognizant today of keeping a safe distance from others. And yes, I wear a mask all the time, even though I'm 6 or 10 feet away from somebody. If I'm with my neighbor and Jim and I want to have a chat, like we always do when you go out and get the mail and see your neighbor, I may not wear a mask, but I'm 10, 15 feet away from him, and we're comfortable doing that because we're outside. So it kind of goes forth and back. I think as we start to open up some, we're all desperate for social interaction. People will have, you'll set up chairs in the backyard and tell each person to bring their own bottle of wine, or each couple, and talk. I don't envision wearing a mask for that. It's hard to drink wine through my mask. But the more you're moving around, passing other people, the more you should have a mask on, yes.
Thank you. Once restaurants start to open again, I guess I'll really start that question again. Do you think it will be safe to start going out to restaurants again once they resume operations?
Let's take the same logic. I personally will go sit at a restaurant when I can eat out of doors.
Okay.
So I'll go to a place with a patio. I'll go to a place where I can sit outdoors. Restaurants will be required to keep us socially distant, so kind of every other table will be empty. I would not go to a restaurant or bar that was crowded. The idea of standing too deep at a bar isn't going to happen. It just can't happen, because that's the really dangerous place. So as we all choose to go out, we will be able to find places and times when it's safe, and places and times when it's not safe. And we'll each have to sort of decide. But the most dangerous thing you can do is be around a crowd.
Okay, from Teresa Regan, how are we doing with testing? I heard that it's now possible to test for the virus using sewer water. Does this lead to the possibility of an in-home test similar to a pregnancy or test or a colon cancer screening?
So the use of they're looking for the genetic material of COVID in sewage, may be a way to tell us how much disease is in a community. or whether the disease is moving into a community. If you could pick it up in sewer water, you may anticipate that you're going to have an outbreak in the near future. So I think that's more for public health use.
Okay.
We're moving away from the long swabs in the back of your nose. Those are very uncomfortable. To a swab in your mouth or saliva. We're moving to more rapid tests that are going to be as easily done as a pregnancy test. But I think for the time being, most of these will be available in your doctor's office. So it'll be more like, my child has a strep throat, I need to go to urgent care. If I had a cough and a fever, I would go, I'd call my doctor at Freighter and I'd say, Dan, I need a test. And he would send me to the drive-in place or an urgent care. And I could get, and today it's possible, you can get a test and get the results very quickly. And we're getting that down to the kind of 15-minute test, which is really where it needs to be. And we're probably going to need millions of those tests a day in the country to open up. Not a few thousand. We're going to need millions. Because in places where you cannot be socially isolated, let's take meat packers. I found the article in the Journal Sentinel really interesting today. Meat packing has to be done with close proximity because the meat moves very quickly because they don't want it out of a refrigerated area. They blow big fans so the air moves around a lot because they don't want germs landing on meat. All these different components and you need a very small space because they keep the room very cold and it costs too much to air condition a big space. So in an area like that, where we're going to have workers who by necessity have to work together, we will probably test them every day. And if somebody's positive, then they don't go into the work because they will infect 20 or 30 other people. Or healthcare workers. So that's where we'll really need to use this test first.
Okay. From Bill Lynch, how do differing strains and mutations impact vaccine development?
That question is probably coming a lot from this question of whether the virus has mutated and become more aggressive, or whether there are 2 or 3 different strains of the virus floating around. Clearly, any mutation in the virus, and viruses mutate a lot, they replicate thousands of times very, very quickly, makes it harder to get a vaccine. But most of the vaccines under development are picking parts of this virus that are unlikely to mutate, or that are more like, if they mutate, I mean, one of the virus vaccines, for example, actually goes after the single protein on the coronavirus that attaches to the ACE2 protein on your lung cells. And when they can stop those two from connecting by interfering with the virus vaccine component attaches over here, then it's a really good vaccine. That's unlikely to mutate because that's part of how the infection spreads. So it just makes it harder. Interestingly, we're probably best off, because of that possible mutations, to get 3 or 4 vaccines. Some vaccines may be more effective for the elderly. Some may be more effective for immediate and short-term protection, some for long-term protection. So we don't know yet, but I've heard that we may have 2 or 3 or 4 vaccines that attack the virus different ways.
Okay. Questions keep coming in here. Besides age, what factors determine the severity of the disease one might experience? That's from Dan Federley.
Sorry, guys. Sex. Men are consistently dying at a rate of 60 to 40. Nobody knows why. But over and over again, all around the world, That's the kind of ratio that we're seeing. So men are more likely to die. I believe I read the other day that 85% of all deaths occur in people over age 65. So it's age and being male.
Okay. Can you share your thoughts on the use of technology like Apple-Google collaboration, like the Apple-Google collaboration to help with tracking? That's from Ryan Daniels.
So let's look at the countries that have done a really good job of stopping this pandemic. Now, most of them jumped to action almost immediately, way back in early February. They saw the problem, their intelligence agencies said, this is a problem, we need to do something, and they did. They immediately began to identify people who were positive and to track them. If you go back to my last talk, I had a slide. Remember the church in South Korea where so many people were infected?
Mm-hmm.
The South Korean government knew within 3 days every single person who was positive and all of their contacts. And then they had, it's a different society and a different culture than America, a means to quarantine, to remove the infected people and keep them from infecting others. Not sort of a nice stay at home, but oh, by the way, here's the converted basketball arena where you're going to stay in a bed for 2 weeks. And everybody who is infected is there. If you get sicker, you go to the hospital. If 2 weeks passes and you're well, and you can then go back to your home. But it's part of how you do this. Because the best way to stop the infection is to find somebody who's positive and then keep them out of circulation. So I personally favor this, particularly at this time in the pandemic. I've heard it argued that it's too late. We have too many people who are positive and it's just not realistic to track them. But I still think it's a very effective tool. You know, in the absence of a vaccine, we have to use the tools we have. This disease is incredibly lethal. It's a bad disease.
You know, we're coming up on our...
But what do we have? Just a second, Mary. What do we have?
Okay, sure.
We have social distancing, we have isolation, and we have masks. That's all we have to stay safe. So we need to use all the tools we have. So I tend to support the tracking.
Oh, that's good. And there's still a few more questions, which I think that we should continue with. If, I suppose people can vote with their click and step away. But in addition to the work being done toward a vaccine, please comment on the progress being made in terms of drugs to treat COVID-19.
Oh, thank you, somebody. Yeah, I meant to mention that.
That's from Pat Cronin.
Thank you, Pat.
Yeah, that was.
So we flattened the curve. And by flattening the curve, we have given the hospitals and scientists enough opportunity to, the sun is coming in the window, enough opportunity to find treatments that are going to work. And as they find treatments that are going to work, remdesivir being one, well, yeah, that's going to, if you're really sick and you're in the hospital and you need oxygen or on a ventilator, it's going to help you get better quicker. But the mortality was only a little bit better and didn't reach statistical significance. What we really want are lots of treatments. So I want a treatment when I'm in the hospital and I'm very sick and need oxygen. I want something that's going to work then. I want something that's going to work when I'm sick at home and reduce my chances of going to the hospital. I want something that's going to work to make my immune system stronger or my lungs stronger or to stop the blood clots that are happening. So as scientists and doctors and nurses begin to understand how to treat us better, then when we have the future waves, we will all feel a little bit more comfortable knowing that if we get sick, there's something that's going to work and reduce our risk of becoming severely ill or dying. And that will make us feel a little better. So they're in the process of gathering all those treatments. Lots and lots and lots and lots and lots of drugs are being tried.
Okay, I think we do have one more question on tracking here. We keep hearing that the US needs more tests, and we also hear that we have tested more per capita than any other country. Are both things correct? Have other countries managed to contain this without the amount of testing that we seem to need? And
America, desperately needs national leadership on testing. We are dismally far behind other countries. We are not the leader in per capita tests.
okay.
We're in fact not in the top 10. And we have done more tests than many countries because we're a bigger country. But in per capita, we're not testing very many. That's problem A. B, we have multiple tests, and the tests all use different reagents or different machines or different timing. We have needed, since February, a national push to develop one or two tests serving different purposes, one for immediate diagnosis and one for, say, confirmation or antibodies, that can be used and mass-produced and that are reliable and accurate, so that the supplies for the different tests can be moved around the country as different areas have clusters. For example, when the meat processing plant in Green Bay had a cluster, did they have sufficient tests, or where did their testing equipment come from? If we were all using the same test around the country, it could go to where it was needed. So we still need, I believe, many people still believe, that we still need one or two nationally consistent, really good tests, so the reagents and the machines and all the equipment can be used where it's needed and moved where it's needed.
That makes sense. Okay, I think there was one other question that I missed along the way from President Steve, I believe, and then we can close on that, which is there a theory that COVID has many different versions, which we've talked a bit about, thereby allow one to test positive without having any symptoms? What about the symptom-free COVID carrier?
So what about the symptom-free COVID carrier? That's really interesting. We don't know much.
Okay.
As we are doing more, most of our tests today have been done when you're sick. And in fact, many people who are sick until recently have not been able to get a test. So we don't know. And as we begin to test populations, so the CDC may walk into a community and say, we're going to test every 100th person and see who has it and who had it and who is symptomatic and who is not. And then we'll start to learn. I am less concerned about the different mutations of coronavirus causing some people to be symptomatic and some to be asymptomatic. I think it's much more likely that it's the same coronavirus. It's our body's reaction to the coronavirus that determines the severity of disease.
Oh, that's interesting.
We will need to find out whether an asymptomatic person has immunity. Maybe they have a different ACE2 receptor in their lung, and the virus doesn't stick very well. We tend to think all the ACE2 proteins in our lungs are the same, but maybe they're not.
Well, that's a nice way to end, I think.
So I want people to stay strong. You know, we've been through really bad stuff before. Our grandparents or great-grandparents went through World War I. They went through the Spanish flu. They went through the Depression. They went through World War II. And America has chugged along. All the time, institutions like Rotary or churches or our basic foundations have come together to guide us through these difficult times. And I tend to think we'll look a lot very similar 5 years from now to what we look like. Hopefully we'll look even better. But John Stuart Mill in 1848, in Principles of Political Economy, wrote, "What has so often excited wonder is the great rapidity with which countries recover from a state of devastation, the disappearance in a short time of all traces of mischief done by an earthquakes, floods, hurricane, and the ravages of war. An enemy lays waste to a country by fire and sword, and destroys or carries away nearly all of the movable wealth existing in it. All the inhabitants are ruined, and yet in a few years after, everything is much as it was before." And that's what I think we're going to see with this. It's a test of character. We can do this, but we need to be realistic and understand that this isn't going to go away this summer. It's not going to be gone by the fall, and we may not have a vaccine for 6, 12, 24, or 48 months. But every step along the way, we'll get better treatment and better understanding of how the virus behaves and better understanding of how to protect ourselves. So until then, the only vaccines you have are social distancing, avoid crowds, wear a mask, and wash your hands. And with that, I thank you, and I look forward to updating you in another 6 weeks.
Well, I thank you, and I know I can hear the virtual applause that we're all beginning to learn to hear at the end of every presentation. Michelle will, this program has been recorded, and Michelle will post it to our website. You'll be able to, or post to the YouTube channel, which you can access through our website. So you can watch it again and share it with your family and friends. As I mentioned, there were 1,800 views to Dr. Bob's first presentation, so it was shared widely, and I expect this one will be shared as well. And so tune in next Thursday at noon, and we will hear from past President Dan Bolite about what we need to be thinking about as we prepare to go back to work from a legal perspective. So thank you again, Dr. Bob, and thanks to all who participated today.
Thank you, everyone.